So today we are going to talk about cirrhosis with portal hypertension. Okay, so far you have learned about hepatitis, and you have seen that some of the hepatitis can go on to become chronic hepatitis. Chronicity can develop, except hepatitis A. All the other hepatitis can cause chronicity, and so the ability to undergo irreversible cell damage. Irreversible cell damage in the liver, the end product is cirrhosis always. And when cirrhosis develops because of the change in the architecture of the liver, the vascular channels are all twisted, and there could be obstruction causing portal hypertension. Okay, so this is a case history which we usually may give to you. This is a very, very important topic, not only in pathology but also in surgery. Okay, and there are many, many cases, especially in the Northeast and especially in Shillong also. So you have to know everything about cirrhosis with portal hypertension. So here we have a case history of a 56-year-old male who's a chronic alcoholic. He presents with abdominal distension, bilateral swelling of feet, loss of appetite, moderate dyspnea past 2 weeks. Remember, each of these words are extremely important. 56-year-old male, okay, chronic alcoholic, very, very important. Abdominal distension, again important. Bilateral swelling of feet. All these lead to what? Basically, if you look at this history, when you think of a chronic alcoholic who's a male who's 56-year-old, so maybe chronic alcoholic must have been 30 years chronic alcohol intake. So how much damage the liver would have undergone? So initially the liver would have been, for the past 25 years, maybe there would have been only fatty liver. But then eventually the insult is, every day. The alcohol is not stopping. The insult is every day. The fatty change proceeds to alcoholic liver disease, which proceeds to chronic hepatitis, and eventually there will be fibrosis of the liver. So when there is damage to the liver, when there's extensive damage to the liver, you know very well that liver synthesizes albumin, and if there is hypoalbuminemia, then you know that the whole oncotic pressure will be changed and there will be development of ascites, okay, so which will present with abdominal distension, okay, and also because of hypoalbuminemia there is bilateral swelling of the feet. So all this is because the synthetic capabilities of the liver is affected. Loss of appetite, this happens in many of the diseases. I don't have a proper explanation for that. But moderate dyspnea basically, if there is severe ascites and abdominal distension, the diaphragm is pushed up. So that will compromise on the space of the lung and it can cause dyspnea. Okay, moderate dyspnea. So this is the definition of cirrhosis. Cirrhosis, first thing you have to remember, is an end-stage chronic liver disease. Okay, this is a favorite question which we keep asking you as a short answer question. Either define cirrhosis or what are the 3 characteristics which define cirrhosis. So you have to mention these 3: bridging fibrous septae in the form of delicate bands or broad scars, parenchymal nodules containing proliferating hepatocytes encircled by fibrosis, and disruption of architecture of the entire liver. We'll go through this definition again at the end of this class. So the features to remember are that parenchymal injury, that means the hepatocytic injury, and consequent fibrosis are diffuse. It is not a focal disease. It affects the whole liver. Okay, so that is one thing which you have to remember. It's a diffuse process. Nodularity. Why nodularity? In alcoholic hepatitis there are no nodules. However, in cirrhosis there are nodules, because parenchymal injury might happen, but all are not uniformly injured. There are some hepatocytes which are still capable of regenerating. So when that happens, there is fibrosis, but supposing those hepatocytes which are surrounded by the fibrosis, some are irreversibly damaged, so they die and get replaced by fibrosis. but some are still able to regenerate. So when they are regenerating, they will regenerate without the normal architecture of the liver, but they will, multiply. Hepatocytes will multiply and they will form nodularity. And this nodularity is the characteristic of cirrhosis. Okay, so remember that in alcoholic hepatitis, there are no nodules, but in cirrhosis, there is nodularity. Vascular architecture is totally reorganized. There is formation of abnormal interconnections between vascular inflow and hepatic vein outflow channels. And like I said, it's an irreversible damage to the liver. Reversal is extremely rare. And liver also contains abundant metalloproteinases and collagenases, which are capable of degrading the extracellular matrix. And like I have already shown you, that reticulin stain is the one which stains the connective tissue. As long as the extracellular matrix or the connective tissue is retained, the reticulin fibers are retained, then when the liver regenerates, it will regenerate with intact architecture. But once the extracellular matrix or the connective tissue is degraded, when the hepatocytes regenerate, they will regenerate without any direction, and they can just form a big mass, and that's how a nodule or a regenerating nodule is formed, which is surrounded by fibrosis. Okay, so are you following me till now? Are you following? Say yes, at least 3-4 of you say yes. I feel happy when I hear your voices. That's a very soft voice. Okay.
Yes.
Okay. Fine. So how will you classify cirrhosis? This is also a short answer question. How will you classify cirrhosis? Morphologically, they can be classified based on the size of the nodules. Okay. So if the nodules are less than 3 millimeters, it is micronodular cirrhosis. If the nodules are larger than 3 millimeters, it is a macronodular cirrhosis. And if they have both, which is most commonly, some nodules are less than 3, some nodules are more than 3 millimeters, then it is known as a mixed micro and macronodular cirrhosis. Now, another thing which is very, very important is that we can ask objective questions on this. We can ask you, name 2 causes of micronodular cirrhosis, and the 2 causes are biliary cirrhosis and drug-induced cirrhosis. Okay, you cannot write alcoholic liver disease here. Alcoholic liver disease is a mixed micro and macronodular. Okay, macronodular is usually because of post-necrotic, like in viral hepatitis, when there is extensive necrosis of the liver with degeneration of the extracellular matrix. Then, like I said, there are regenerating nodules which form. Those are usually macronodular cirrhosis. Okay. Then mixed is in alcoholic cirrhosis and hemochromatosis. So this is a very, very important slide. And this is a classical picture. What will you classify this as? Micronodular, macronodular, or mixed? This is a liver.
Mixed.
It's mixed. Very good. Okay. What is this greenish thing here? You see the surface is green. What is that green stuff? This is liver. So what is the green stuff?
Bile.
Bile. Yes, very good. So in this case, in the liver, you get bile stasis. Okay, because the architecture is destroyed. So you just imagine that the architecture is destroyed. So you know that if the architecture is normal, bile is formed in the hepatocytes, goes to the bile canaliculi. All the bile canaliculi get together and go and join the hepatic duct, which joins to form the common hepatic duct, and it goes through the cystic duct into the gallbladder, and that is how bile is produced in the liver and stored in the gallbladder, right? But now if the architecture is totally transformed, where will the bile go? The biliary canaliculi are all blocked. So when they are all blocked, there will be bile lakes. Microscopically, you will see bile lakes, which is also cholestasis. Okay, and grossly, this is what you will see. You will see the greenish tinge. Okay, this is because of bile stasis within the liver. Okay, now look at this picture. What stain is this? What stain is this? Blue.
Mason strichrome.
Mason strichrome. I know that I hear the same voice in every class. Okay, it's Uday's voice or I don't know whose voice. but this person only answers my questions. It's really difficult in an online class. I don't like it, but we are forced to. Okay, so this is Masson's trichrome stain, which actually stains mature collagen. So you can see here that this is irreversible damage of the liver, where you can see this reddish things are the hepatocytes. They are the regenerating nodules, and they are surrounded by fibrosis or collagen. Okay, there are sometimes thin band of fibrous or very thick band of fibrosis. Here though it's totally damaged, the hepatocytes. Here you have larger nodules. So this is a mixed micronodular and macronodular cirrhosis of the liver with bile staining on the surface. This is a Masson's trichrome showing you the multiple regenerating nodules without any architecture. Architecture is totally lost, and you can see the thick bands of fibrosis. So this is a classification of cirrhosis based on the etiology. This one which I was trying to show you is based on the morphology. So this is a short answer question. The morphological classification of cirrhosis. You have to answer this, and you have to give at least 1 or 2 examples for each. If we ask as an objective question, we usually put it as name 2 causes of micronodular cirrhosis. Okay. But in a classification of cirrhosis based on etiology, this is what are the various etiology which can clinically progress to cirrhosis. And you can see 60 to 70% of all cases are due to alcoholic liver disease. Okay, that's why this is the most important. 10% is because of viral hepatitis. That's why we have taken a class on these 2. National Medical Commission has put competencies based on only these 2 because they are the most common. Okay, the alcoholic liver disease and viral hepatitis are the most common cause of cirrhosis. And I want you to take a look at the other causes, and remember that even though we will not ask you long questions on this, but still objective questions may still come on any of these. Okay, so I think I have sent you videos on hemochromatosis, Wilson's disease, and NASH. I think these are the ones I have sent. Okay, and in this class I'll cover a little bit about biliary disease. Not much, but a little bit. Okay. So the pathogenesis of cirrhosis, this is another favorite question. So the central pathogenetic processes in cirrhosis are progressive fibrosis and reorganization of the vascular microarchitecture of the liver. Remember these words which I have marked in red. These are words which you should use. I don't like mugging up things, but the fact remains that you have to at least try to remember some of the words which make scientific sense. Okay. So progressive fibrosis is not at all difficult to remember, and because of the fibrosis in the liver, obviously the architecture is totally transformed, and the vascular microarchitecture also will be transformed, and it has to be reorganized. Okay, so these are the 2 points I want you to remember: progressive fibrosis and reorganization of the vascular microarchitecture of the liver. So the pathogenesis is that initially there is liver cell necrosis, and regeneration is possible if some of the hepatocytes still has reversible cell damage, not really necrosis. Necrosis is irreversible. If the liver cell has undergone necrosis, there is no way it can regenerate. It's only because if you see necrosis, there will be still 1 or 2 cells hiding within that necrosis which still have just reversible cell damage, and those are the cells which can regenerate. Remember that. Okay. Fibrosis is stimulated by lymphocytes. You have read inflammation. You know the ability to cause fibrosis in any inflammation is because of the cytokines. Okay. So lymphocytes, polymorph, Kupffer cells, all of them contribute in this inflammatory process by producing a whole lot of cytokines. And these cytokines will initiate excess collagen. Okay, and but the major source of this excess collagen is actually the stellate cells. The perisinusoidal stellate cells, when activated, they are the ones which cause the excess collagen, apart from the cytokines from the inflammatory cells. shift from the resting state lipocyte phenotype to a transitional myofibroblast phenotype. Myofibroblast basically is a fibroblast which has the capability to retract. That's why in cirrhosis, the size of the liver will eventually shrink. It will be reduced for size. Okay, initially the whole process, the liver is enlarged in size. But in the very late stages of cirrhosis, the liver becomes much smaller in size, mainly because of the this phenotype change. The myofibroblast has the capability to contract. Okay, and increased capacity for synthesis and secretion of extracellular matrix. Mainly the extracellular matrix is the one we need for architecture, but if there is excess of it, it just forms fibrotic bands. And that is what happens in cirrhosis because of inflammation. All cytokines are produced from the inflammatory cells, and the stellate cells are the ones which produce excess collagen. Okay. So these are the sources of stimuli for the stellate cells: chronic inflammation, tumor necrosis factor, lymphotoxin, interleukin-1, cytokine production, all of these, transforming growth factor, platelet-derived growth factor, lipid peroxidation. All these cells can also produce these cytokines. So there is disruption of the extracellular matrix, as stellate cells are extraordinarily responsive to the status of their substrate, and direct stimulation of stellate cells by toxins can also happen. So the basic center of production of collagen is based on the stellate cells. Okay, and all these are the sources which can cause the stellate cells to lay down so much collagen in the liver, making it undergo fibrosis. Okay, so this is a picture from your Robbins. This is how the normal liver is. Please concentrate first on this first picture. You know very well that the hepatocytes are there, the nucleus, nucleolus, cytoplasm, okay, and these green things are the bile canaliculi. So like the hepatocytes produce the bile, goes to the bile canaliculi all get together and form the, join the hepatic duct, and the transportation of the bile continues. And here, between each line of hepatocytes, there is the sinusoid. Okay, the sinusoid is always lined by endothelial cells and also Kupffer cells on the luminal side. But there is a space between this endothelial cell lining and the hepatocyte, and this space is known as the space of Dicey. In this space of Dicey, there are stellate cells. So this stellate cells initially is inactive. But in the event of inflammation of the liver, there are so many cytokines reacting to it that these stellate cells will multiply, they get activated, and they have the capability of, okay, so stellate cell activation and fibrosis. So here you have the space of this. You can see here this is an inactive stellate cell, but here these stellate cells have become active. They are reacting to all the cytokines from the inflammatory cells, and they transform into myofibroblasts. That's why they have changed in shape here. They look fibroblastic, and they lay down a lot of collagen. Now the problem with laying down a lot of collagen is that whatever channels are there, like even the bile canaliculi or whatever synthesis the liver cells does, they secrete into the sinusoid. But if this space of this is filled with fibrosis, whatever the poor hepatocyte tries to produce, it will not be able to transfer its goods to the sinusoid. And that is how the synthesis is affected. Apart from, of course, the hepatocyte itself undergoing apoptotic or dysfunction and death. Okay, so you have to remember this picture. We want you to recapitulate this picture when we ask you the question of pathogenesis of cirrhosis. We expect you to write down this picture and write all these cytokines which are involved in the proliferation, contraction, chemotaxis, and fibrogenesis, and the transforming of the stellate cell into a myofibroblast. Okay, so this is the basic pathogenesis of liver fibrosis or cirrhosis, and this is a very, very common question which is asked. So like I've already said, surviving hepatocytes are stimulated to regenerate and proliferate as spherical nodules within the confines of fibrotic septa. So the end result is you have a fibrotic nodular liver in which delivery of blood to hepatocytes gets severely compromised, as is the ability of hepatocytes to secrete substances to the plasma, and the biliary channels or the bile cannulae are all obliterated, leading to jaundice. Okay, so in cirrhosis of liver, it's a sort of intrahepatic obstructive jaundice, and you can get unconjugated. There may be a bit of high conjugated also. If there are some hepatocytes which are able to conjugate, you may get both conjugated and unconjugated bilirubin being raised. Okay, so I hope you have understood the pathogenesis of cirrhosis. Let's come back to the definition. I hope you understand now why these three words are so important. The three characteristics: bridging fibrous septae in the form of delicate bands or broad scars. That is one characteristic. Then, because of these fibrous septae, if there are regenerating hepatocytes, they can form parenchymal nodules, which are encircled by fibrosis. And because of all this, there is disruption of the architecture of the entire liver. Okay, so these are the three characteristics, and I told you this is a very, very important question. What are the consequences of cirrhosis? You know this already. It prevents normal flow of nutrients to the hepatocytes. There is decreased synthesis in the liver because of hepatocyte degeneration. Increased vascular resistance because the vascularity is all blocked up or it's reorganized. Portal hypertension can occur. Obviously, this you know that 70%, 75% of the blood flow to the liver is through the portal veins, and all those portal venules are all disrupted. So there is backflow into the spleen. If there is backflow into the spleen will undergo congestion. So there will be splenomegaly. A very large spleen will be palpable, and congestive or CBC spleen may be there microscopically. And ascites, because of the synthetic ability of the liver is compromised, hyperproteinemia is there, and portal hypertension can also cause a lot of changes in the osmotic pressure in the vessels, and that can also contribute to ascites. And varices, these varices happen at various places in the venous plexuses, which I'll show you a picture. Then toxic substances bypass detoxification in the liver and spread systematically, because most of the drugs we take or anything which we eat, any toxic substance is metabolized by the liver. In this case, they cannot. So they bypass the liver, and because of that, all the toxin substances go to the GIT and they are reabsorbed in the GIT vessels, and they can cause problems. So clinical features: 40% are asymptomatic. This is the danger. It's because most of the people who take alcohol, they do not realize the danger that they are destroying the liver. Now, most of them do realize it, even if we tell they are not bothered. But 40% is asymptomatic. Because they are asymptomatic, they keep drinking. Okay, they will have weight loss, they don't mind. Anorexia, they don't mind. Weakness, they don't mind. Okay, only when they go into a stage of liver failure, then only they start minding, and it has already become too late. Okay, and you already know the symptoms and signs of liver failure, so please go through it. Hepatopulmonary syndrome can occur, okay, and death can be due to progressive liver failure, complication related to portal hypertension, and also development of hepatocellular carcinoma. So portal hypertension means that there is increased resistance to portal blood flow. So again, portal hypertension can be classified as prehepatic, intrahepatic, and posthepatic. Okay, so prehepatic means before entering the liver, there may be obstructive thrombosis and narrowing of the portal vein. This usually happens, it may happen not because of, portal hypertension is not only secondary to cirrhosis, remember that. Only the intrahepatic is the one which is due to cirrhosis. But this is the one which accounts for most of the cases of portal hypertension. Okay, and this is the cases which you will get in surgery, cirrhosis with portal hypertension secondary to alcohol. Now, I just want to tell you that when I was a student, I was a final year student, I was in surgery, we got a case I got, usually they always show us cirrhosis with portal hypertension. They will always show us an elderly gentleman who's a drunkard and he's got a huge abdomen. And I used to call those pregnant men. And we were quite happy with getting cirrhosis with portal hypertension cases because we had been shown so many cases. I was very confident that if I get a cirrhosis with portal hypertension, I will pass the exam. Okay. So now what happened is they did not. It so happened that when our exam was there, they did not have a case of cirrhosis with portal hypertension, which was the usual case, which was a alcoholic, which was a man who's elderly with a huge ascites. So they didn't have such a case. They put a portal hypertension case. They gave me a 16-year-old girl who looks completely normal. Okay, she didn't look like she was losing weight, and obviously 16-year-old girl, obviously not an alcoholic. So I had read only about the cirrhosis because that's the most important cause of portal hypertension. I didn't really remember the pre-hepatic, intrahepatic and post-hepatic causes of portal hypertension. So in this case, they gave me a 16-year-old girl. She did not have ascites. So I asked her as much as possible, history and all that. And she just told that from when she was a kid, she had some problem. And then when I palpated, I felt there was a mass on the left side of the abdomen. Okay. And I didn't understand because, we were not shown such cases. So I was really scared, like, what is this mass? Then I felt it. I made her lie prone. I examined the mass and I thought it was a renal mass. So my viva went haywire because I just didn't know what was happening, and obviously I flunked. Okay. So I failed that particular exam because I really messed up with the clinical case. So why I'm telling you this story is that sometimes, we stress only on the most common, we overlook the other things. So please don't overlook. Portal hypertension, most commonly, yes, it is the intrahepatic cirrhosis. But in the pre-hepatic, that means this usually occurs, and when the baby is born, umbilical cord infection can lead to thrombosis, and that thrombosis can go up and it can cause a narrowing or a stricture of the portal vein, and that person will have problem throughout their life. Okay, so that is the pre-hepatic cause of portal hypertension. That mass which I palpated on the left side was actually splenomegaly. It was a CVC spleen. It was a huge CVC spleen, which I didn't understand what was going on with that case. Okay, so just remember that even though we stress on the most important, but you have to know other less likely causes of cirrhosis with portal hypertension. So pre-hepatic usually in very young people. Intrahepatic is the usual history which I told you just now. Post-hepatic can happen due to any of these. Okay, be aware of it. So remember when I showed you that slide where we said that there is some varices. So what are these varices we are talking about? We are talking about this whole picture shows you the portal circulation. And the most common varices which the cirrhosis with portal hypertension gets is they present with hematemesis. Hematemesis means vomiting of blood. So that is because of the varices here. Okay, because of this resistance and the backflow and all this of this, this is the spleen here, dotted line. Okay, and because of the resistance here, because of the CVC spleen has grown very big, and these portal veins get dilated and there is backflow. So there will be multiple vascular channels opening up around these capillary or venous plexuses. So at the level of the esophageal, gastroesophageal junction, there can be multiple veins which are dilated and tortuous, and that is why it is known as varices. So because they are at the level of the esophagus, they are esophageal varices. And these esophageal varices, they occur just below the mucosa of the esophagus. They are dilated, tortuous, and they're just below the mucosa of the esophagus. So they are very liable to get traumatized. When they get traumatized because of vomiting or retching, the patient will actually vomit out blood because these vessels rupture. Okay, so that is the presentation of cirrhosis with portal hypertension. Most common presentation is esophageal varices, and like I said, they are dilated, they are tortuous, they're very superficially under the mucosa. Whenever the patient has vomiting, they may rupture and the patient may vomit blood out instead. Okay, so that's how they have hematemesis. So this is one varices which is very important. Another one which is very important is the one around the rectum. Okay, and this in layman terms is known as piles. So the same thing here, again they are dilated, they are tortuous, they're just beneath the mucosa. Whenever this excretion is there, it may rub against the mucosa, those might get ruptured, and there can be melena. Okay, or there can be fresh blood in the stools rather than melena. It's usually fresh blood in the stools because of the leaking of blood from the ruptured varices around the rectum. Okay, so these are the rectal varices and these are the esophageal varices. Another thing which can happen is around the umbilicus, which I don't know, they have not shown here. Yeah, this one. Okay, so this is the skin, this is the umbilicus. Can you see this bit of vein, umbilical vein comes? Okay, again there can be tortuous veins here, and you can see it as enlarged veins are at the umbilical level. Especially when the patient has ascites, there is a huge abdomen and you can still see the veins radiating from the umbilicus. Okay, so that's another varices which is important. So portal hypertension and cirrhosis, the pathogenesis is that it results from increased resistance to portal flow at the level of the sinusoids, which is more than 12 millimeter mercury. This is important, especially radiologically, because radiologically they diagnose portal hypertension by measuring the pressure within the portal veins, and they also look at the dilatation of the portal veins apart from the splenomegaly, of course. Okay, so this is how radiologists will diagnose portal hypertension, mainly measuring this resistance to portal flow. Compression of terminal hepatic veins by perivenular scarring and expansile parenchymal nodules can be there. Like I said, basically the whole architecture is revamped. The vascular microarchitecture is totally blocked, and that is why the resistance is so high and the pressure will go up. Then anastomosis between the arterial and portal systems in the fibrous septa also contribute to portal hypertension by imposing the arterial pressure on the low pressure hepatic venous system. This is very, very important. An increase in portal venous flow resulting from hyperdynamic circulation because of this arterial pressure being pushed towards the low pressure venous system. So that is why those whichever I was talking to you about portosystemic shunts is with rise in portal systemic pressure. The flow is reversed from portal to systemic circulation by dilation of the collateral vessels and development of new vessels. Venous bypasses develop wherever the systemic and portal circulation share common beds. Esophageal varices is there in 40%. Hematemesis in death occurs in half of them. Congestive splenomegaly. And there is something known as hypersplenism. Basically, you know that spleen is the region where most of the RBCs, which are all get, it's their symmetry, you can say. Okay, so you know that spleen is involved with culling and pitting and all that, destroying the old aged RBCs. So in this case, the spleen is very, very large. Okay, so when the spleen is very large, there is pooling of blood. When there is pooling of blood, the platelets get pooled within the spleen, and when you test the CBC, when you do the CBC of the patient, there can be thrombocytopenia because the pooling of the platelets within the spleen. Another thing is the spleen is also proactive. It destroys even RBCs which it's not supposed to destroy. So even anemia can set in. And it can also pool the WBCs. Even leukopenia can be there. So hypersplenism basically means that the spleen is overreacting and you can get pancytopenia in the peripheral blood. You can have anemia, you can have leukopenia and thrombocytopenia, mainly because pooling of the WBC and platelets and destruction of the RBCs in the spleen. That is known as hypersplenism. Okay. So these are the clinical consequences of portal hypertension, and most of them here you'll see that they do overlap with liver failure as well. So pedal edema and ascites, I don't think I need to explain to you this. Icterus also, pruritus also, these are all secondary to cholestasis. Okay. Hematemesis, I've already said. Easy bruisability can happen because like I said, thrombocytopenia can happen because of hypersplenism. So obviously if platelets are low in the peripheral blood, there can be easy bruisability. Palmar erythema means that in the palms there can be reddish hue. That's all because of the vascular circulation which is revamped. Spider angiomas are these things just under the epidermis. The capillaries may be dilated because of the increased pressure in the capillaries, so they become dilated and you can see them just beneath the skin. These are known as spider angiomas. Varices or hemorrhoids, the piles which I showed you in the rectum, this one. Weight loss and muscle wasting bound to happen. Parotid enlargement can happen. This is something in portal hypertension. There is an explanation for it. I don't know really why. Testicular atrophy is because of the liver failure. Estrogen is not detoxified in the liver, so estrogen increases. So there's testicular atrophy. There will be gynecomastia. Okay. Sleep pattern is altered, causing confusion, that's because of liver failure. Ammonia gets to the brain and causes hepatic encephalopathy. Okay, so this picture is also from Robbins. You can go through it. So the pathogenesis of ascites, this it's good to read. Sinusoidal hypertension. We may ask you pathogenesis of ascites in cirrhosis. Okay, so remember these points. It's not only hypoalbuminemia, which I know all of you know very well, hypoalbuminemia, how it can lead to ascites. Basically, this Starling's forces are altered, driving fluid into the space of this, which is then removed by the hepatic lymphatics. This is because of sinusoidal hypertension. Percolation of the hepatic lymph into the peritoneal cavity. Hepatic lymphatic flow may approach 20 liters per day, exceeding thoracic duct capacity. Splanchnic vasodilation and hyperdynamic circulation. Renal retention of sodium and water due to secondary hyperaldosteronism. All of these are causes of ascites. Please remember, because what we usually get from you when we ask pathogenesis of ascites is all of you write only about hypoalbuminemia. It's good to at least remember some of these causes. Okay, so that covers alcoholic liver disease with cirrhosis and portal hypertension. That is an extremely important topic in liver. Okay, expect questions from it. I've already told you which are the important questions. Now coming to biliary cirrhosis, I don't expect to ask you any questions here. The only thing which we usually ask is an objective question. Biliary cirrhosis usually cause micronodular form of cirrhosis. So that can be an objective question. You have to remember that. Okay, but you do have to remember that biliary cirrhosis is a intrahepatic biliary tract disease. Intrahepatic is very important word, and they can be primary or secondary. Primary probably is due to inflammatory or autoimmune disease, and it's most commonly in females. Okay, and secondary is because of extrahepatic cholelithiasis, malignancy, or strictures. Okay. Clinical features: because of the jaundice, because of the bile pigments deposited in the skin, there is pruritus, malaise, dark urine, light stools, typical of obstructive jaundice. Hepatosplenomegaly. Lab findings: there can be conjugated hyperbilirubinemia, ALP or alkaline phosphatase is raised, bile acids, cholesterol, antimicrobial antibodies may be seen. And microscopically in the secondary, there can be bile stasis in bile ducts, proliferation of the bile ducts, and portal tract edema. In the primary, there is dense lymphocytic infiltrate in portal hypertension with granulomatous destruction of bile ducts. One thing which I forgot to inform you about alcoholic liver disease with cirrhosis in portal hypertension, there is a line, especially in the Indian population, cirrhosis with portal hypertension is usually secondary to alcoholism, and it's usually in males because most of males go into alcohol. However, if a female is an alcoholic, it hits her very rapidly. Males can be alcoholics for 30 years, 40 years, and then only develop cirrhosis with portal hypertension. But females, if they are alcoholics even for 5 or 10 years, they may develop cirrhosis with portal hypertension very early because their liver does not have the capability to metabolize alcohol I mean, that is one of the reasons they have quoted. I don't really know very true, but this is one of the theory they have put, that females cannot detoxify alcohol as well as males. Okay, so that is one thing I want you to remember. In females, if they are alcoholic, cirrhosis with portal hypertension sets in very early. So this is a picture which may be shown to you. I've noticed that NEET exams, they always put pictures nowadays. So please remember to go through all the pictures in Robbins, very important, because if you see this picture, which is from Robbins, you'll see that it's yellowish and greenish. Okay, so biliary cirrhosis has this greenish tinge, you know, the whole thing will be bile stained, yellowish greenish like this. And if you can see, this cut section has very tiny nodules, all of them less than 3 millimeters. Okay, so this is a micronodular cirrhosis, and this whole slice of liver is stained with green and yellow, which is basically bile. So this is a typical gross picture of a biliary cirrhosis. Okay, so remember, this picture indicates biliary cirrhosis. One thing is, when cirrhosis is established, and we get a biopsy at the when cirrhosis is already there, it is almost impossible for the pathologist to say what is the cause of the cirrhosis. Okay, we cannot, once the damage is done, the fibrosis has set in, it is impossible for us to say whether the cirrhosis is because the patient has had hepatitis B or whether the cirrhosis is because of alcohol. Okay, it is difficult. So the clinical information is extremely important. The clinical history which the patient gives, that is the most important for you to establish the etiologic diagnosis of the cirrhosis. Okay, so back to basics, it's always the clinical history which forms the basis for you to go for further examination, further investigations, and further interpretation of all which you have in your hand. Okay, so remember, you cannot supersede a good clinical history. Now, drug and toxin-induced liver disease, this is another cause of micronodular cirrhosis. If you remember, those are the two causes. So this is, we don't ask you questions on this, so I'll just go through it. Okay, then alcoholic liver disease. This one I have not really touched on alcoholic liver disease. It goes on to cirrhosis, but alcoholic liver disease is also one very important question for you. You have to know that chronic alcohol consumption causes hepatic steatosis, meaning that there is fatty liver. Alcoholic hepatitis can happen, meaning that there can be injury or inflammation of the hepatocytes, and cirrhosis, which you already know what is cirrhosis. Okay, so collectively, if you see these, it is referred to as alcoholic liver disease. So this is the clinical progression. This is a normal liver. If there is exposure to alcohol, repeated exposure, there is hepatic steatosis. Hepatic steatosis means that there is fatty change of the liver with perivenular fibrosis. At this stage, there is absolutely reversible. With abstinence, stoppage of alcohol, it can go back to being a normal liver. However, with continued exposure to alcohol, it can go on to produce cirrhosis, which basically is a combination of hyperplastic nodules and fibrosis. Okay. Or with severe exposure, sudden binge of alcohol may lead to develop hepatitis, in which there can be liver cell necrosis, inflammation, Mallory bodies, fatty change. Okay, and repeated attacks of alcoholic hepatitis will go on to produce cirrhosis, the irreversible stage. Okay, but sometimes you know very well that a young boy, very innocent, with his friends, you know, peer pressure, going to a party, never had alcohol before, being forced to drink alcohol and having a sudden binge of alcohol. This severe exposure of alcohol may cause alcoholic liver hepatitis, alcoholic hepatitis, which can cause liver cell necrosis and inflammation. Okay, so this episode may be there. If he survives this episode and abstinence, it may go back to being a normal liver, or sometimes even with abstinence, it may remain as a fatty liver. Okay, so this is the clinical progression of alcoholic liver disease. So this, as you know, it's there in your skills atlas, is a liver which is very enlarged, appears yellowish and appears very greasy and shiny, And this is the typical picture. This is the normal hepatocytes. These are the fat-filled hepatocytes, which is the steatosis. And these are stains for fat. This is a red colored stain, oil red O, and this is a black colored stain, which is Sudan black 4. So these are stained for fat. And remember here on H and E, if you can see, fat always is colorless because they don't take up the stain. It's not because they don't take up the stain, sorry. It's because when we process tissues for pathology, we process it through alcohol. So the alcohol takes up all the fat, okay, and the fat is lost. So on H and E, we cannot, the H and E cannot stain the fat, so it remains colorless, okay, because the fat has all been taken up by the processing of the tissue. So that's why to stain for fat, you need a frozen section, okay. So frozen section is basically that you do not process the tissue normally, you just freeze the tissue, make it very hard, and then cut it, a live tissue you're cutting at the frozen state, and then only you can stain for fat. Okay, so this is oil red O and this is Sudan black 4. So the morphology of hepatic liver, this you know, the microvesicular means when there are small lipid droplets, macrovesicular means when they are large, like the picture I showed you just now. And initially everything is centrilobular, like what I have explained to you about zone 1, 2, 3. Centrilobular is the zone 3 which receives the least of the oxygen and the nutrients. So they are the ones which are which most undergo changes due to any injury to the liver. So grossly you have a soft organ that is yellow, greasy and enlarged. So alcoholic hepatitis, you get hepatocyte swelling and necrosis. And Mallory bodies. Mallory bodies are very important for you to know. They are objective questions which we ask. Okay, and these are basically cytokeratin intermediate filaments. And they are visible as eosinophilic cytoplasmic inclusions in degenerating hepatocytes. They are characteristically seen in alcoholic liver disease, but they are not specific. They may also be seen in primary biliary cirrhosis, in Wilson's disease, chronic cholestatic syndromes, hepatocellular tumors. Okay, and neutrophilic reaction may happen if there is necrosis of the liver cells. You may have neutrophils coming around that. Lymphocytes and macrophages can also enter the portal tracts and spill into the parenchyma. And fibrosis, you can detect by doing a reticulin stain, and cirrhosis you can detect by doing a massive strichrome stain. So fibrosis is sinusoidal and perivenular fibrosis. Cirrhosis is irreversible. Hobnail appearance, basically hobnail is that boat pins. Now you've seen in those soft boat, we used to put those boat pins which pop out of the surface. So hobnail is that the liver surface will have some things popping out because of the regenerating nodules. That is a hobnail appearance of the liver. Okay, so these are Mallory bodies. There's eosinophilic inclusions within the cytoplasm. Okay, and this is around the hepatocytes there is inflammatory cells. And this is in early fibrosis, which can be detected by doing a mass and strichrome. Okay, you can see that these bands of fibrosis is only around the portal tract and a little bit away, but not real thick bands. Now, alcoholic cirrhosis, very, very common. Here, initially, the liver is always enlarged, okay, more than 2 kgs. However, like I told you, with time and with fibrosis, and stellate cells have the capability of being myofibroblasts, which can shrink. In that case, the liver will change into a brown, shrunken, non-fatty organ which is less than 1 kg. Okay, so this, remember, in the late stages of cirrhosis, the liver will actually become shrunken. And this alcoholic hepatitis may develop within 1 to 2 years. Initially, fibroseptae are very delicate. Regenerative activity of entrapped parenchymal hepatocytes can cause micronodules, hobnail appearance on the surface of the liver. All this I have spoken to you. Broad expanses of tough pale scar tissue is known as Lennec cirrhosis. When there is really broad bands of fibrosis in the liver, that is known as Lennec cirrhosis. So this is a typical morphology of alcoholic cirrhosis, which we've also already gone through. So points to remember is that 10 to 15% of alcoholics develop cirrhosis. Women are more susceptible to hepatic injury. It could be because of genetic susceptibility, because even men, some of them develop cirrhosis quite early. So everything nowadays actually boils down to genetics. You know, if you see whether it's malignancy or inflammation, anything, it boils down to the genetic susceptibility. Okay, so women are more susceptible, but there are some men who are also more susceptible, maybe because of genetic susceptibility. Cirrhosis may develop without antecedent evidence of steatosis or alcoholic hepatitis. So it needn't be that a patient has to go through that same clinical progression which I showed you. It may develop into cirrhosis without any explanation to us. Okay, so there's no safe upper limit for alcohol consumption, and comorbid conditions like iron overload, HBV, HCV can increase the severity of alcoholic liver disease. So the effects of alcohol and its byproducts on hepatocellular function. The hepatocellular steatosis results from alcohol dehydrogenase with acetyl dehydrogenase. It can cause this. You please read up all this stuff. I think it's much easier if you read it up. Okay. And ethanol also can be directly toxic to the hepatocytes. Lab features, obviously LFT will be deranged, serum bilirubin will be raised, alkaline phosphatase, SGPT, prothrombin time is very important. Whenever there is a liver disease, prothrombin, coagulation disorders may get deranged. Okay, I mean coagulation disorders may set in because of the PT being deranged, and altered albumin globulin ratio will be there. Alternatively, there might be no clinical or biochemical evidence of liver disease, and severe hepatic dysfunction is unusual. Causes of death can happen because of hepatic coma, massive GI hemorrhage or hematemesis, intercurrent infection can happen, hepatorenal syndrome following a bout of alcoholic hepatitis, and hepatocellular carcinoma in 3 to 6% of cases. Okay. Now, this also we do not ask you questions, but the fact is you have to know something about everything, and this is one of the diseases which happens in India. We have seen, especially with malnourished children, they can have a non-cirrhotic type of portal fibrosis. It presents with GI bleed, there's female preponderance, splenomegaly may be there, and maybe because of bacterial infection of the gut causing septic embolization of the portal vein. Okay, and fibrosis of the portal vein branches happen. The liver function test will be normal. Microscopically, there will be variable fibrosis, portal tract, obliteration of the small branches of portal vein. So there can be portal hypertension because of non-cirrhosis as well.